Hello. Can the mic hear me? Yeah? Good? Yes, great. Well, good afternoon to you all. It's so wonderful to see you all here and at a session like this. I think malnutrition is one of those that you don't randomly find yourself in a malnutrition session. So I'm assuming everyone who's here cares very deeply about the topic, and so just wanted to thank you for your time here. I'd like to thank the World Health Summit for recognizing the importance of this topic and having us all here, and to Abbott for helping to fund this session, and to all my colleagues who you'll be hearing from today. I'm very excited for this session. So my name is Andrew Musoke. I'm the Chief Operating Officer of SEED Global Health. At SEED, we work with governments in Malawi, Sierra Leone, Zambia, and Uganda to train the health workforce, working directly with the ministries of health, the health education institutions, and the health facilities. So we're excited to be here. Maybe let me let my colleague Fatiha introduce herself first, and then we'll get started.
Thank you very much, Andrew. Good afternoon, everyone. I hope everyone had a good lunch. Nutrition is key, and you had coffee, so you stay awake. I also want to begin by thanking our partners and also the organizers of the World Health Summit for bringing us together today to discuss a very critical issue. This session is to focus on two deeply interconnected priorities, that is, preventing malnutrition at the community level, but also strengthening the primary workforce to make that prevention possible. But before we start discussing, let me introduce myself. My name is Fatiha Terki. I have a medical background. I am specialized in epidemiology and anthropology. I initially headed the immunization program in my home country, and then my international career took me to Geneva. I worked for the Global Fund to fight HIV, AIDS, and malaria. Worked also at WHO, and then at WFP, was the deputy director for the nutrition division before moving as a country director in Senegal. And this is where really we see the work concretely at the community level, and then moved briefly to Burundi, to DRC too. And finally, a year ago, I joined the Committee of Food Security in Rome. It's a committee that is hosted by FAO and also supported by what we call the Rome-based agencies, that is the World Food Program, IFAD, and FAO.
Great, welcome Fatiha. So I'll start by apologizing for a couple of things on behalf of the organizers. First, sorry to our colleagues behind. We love you, and we're thinking about you as yeah. It will sort of be like the backup choir as we speak with the choir. And then second, they called this a fireside chat, but I was looking for the fire, and there's no fire. So we'll just have to pretend and have a chat, a nice cozy chat as we talk today. So maybe just to frame this discussion for us from a global level, it goes without saying for everyone who's here today and this week, health systems are stretched thin. We've been talking about the concept of resilience. Resilience is stretched thin all across the world right now, with conflict, with the cuts in foreign aid, with the effects of extreme weather that are actually impacting our health globally. The theme of this conference, Fatiha and I were discussing earlier, is the right tense fragmenting or fragmented as we talk about this world. And in some cases, it is already fragmented. And in many cases, it's fragmenting. And so the discussions we have today are really to arrest the concept that we should all accept that this world should be fragmented. It shouldn't be. And together, the ideas we bring around strengthening our health system, the world has evolved rather rapidly. The changes in foreign aid have led everyone to feel like the world is collapsing, right? The global health and others are collapsing, but they are not. I think the discussions we're having around how we evolve and how we think more innovatively about financing, about restructuring programs is actually really important. And so specifically, the discussion on malnutrition is taking place in a backdrop where we're seeing primary healthcare systems really stretched thin. Malnutrition is the underlying cause. Nearly 45% of under 5 deaths are related to malnutrition. In sub-Saharan Africa, 1 in 3 children are stunted. Their growth, and stunting is not just about their growth, but it's their learning and their future earning potential. And when you talk about that one child, you're really talking about the whole community. Without that future earning potential for that one child, you're actually talking about the whole community, the ecosystem around that child. So even if we're at a health conference, World Health Summit, the discussions we're talking about are not just about health statistics, but they represent those lost futures, those families in crisis, and the weakening of societies due to these gaps. So that's why this topic is really important. It's not just a topic about malnutrition, but it's a topic about strengthening primary healthcare systems and strengthening societies from within. SID Global Health, the organization that I'm privileged to serve at, has trained over 45,000 health workers over the last decade, serving 76 million people within Africa. A key tenet of the work that we do has really been focused on that health worker, the health workers as the key leading level of change within the health system. And so as we talk today and hear some of the examples from our colleagues today, you'll hear that resounding theme that even as we're addressing malnutrition, even as we're addressing strengthening health systems, it's really around the health worker as that center of the health system. Every trained health worker is a nutrition worker. It's not set in a silo within that. So Fatia, maybe I'll ask you the first question with setting that context for us. In your work, how have you seen the role of strengthening primary health care and dealing with malnutrition? If you could just share with the audience.
Thank you very much. So let me just say a few words about the committee for those who do not know about the committee. So the Committee of World Food Security is the foremost inclusive international and intergovernmental platform in the field of food security and nutrition. So in addition to more than 130 governments that are members of the committee secures seats for the civil society and the indigenous people. We have also a seat for the foundation and a seat for the private sector. So in this respect, the committee within the UN system is unique because there is no other committee where you can find the civil society. And the work of the committee is informed by a high-level panel of experts on food security and nutrition. We call it the HLPE. And just to explain that, the committee will come up with policy recommendations for the countries to implement. So we are assisting countries in their implementation of their programs on food security and nutrition that are evidence-based, because the high-level panel of experts will come up with a report. They will present it to the committee, and then we'll be working on policy recommendations that are negotiated by member state. So all the policy recommendations are negotiated, which is extremely important. And I wanted just to say a word about the chair of the committee. She is Her Excellency, the Ambassador of South Africa in Italy. And I'm talking about her. Her name is Nosifo Jezile, because for her, nutrition is really important, and she is always looking into how we are, as a committee, integrating nutrition. And again, even within the committee, we talk a lot about food security, food insecurity, and sometimes nutrition will fall between the cracks. So she's always there reminding everybody of the importance of nutrition. So let me go back a little bit to the burden of malnutrition today. I'm sure all of you know, we know all that nutrition is a fundamental driver for health for all age groups. And we know also that malnutrition in all its form, because we are talking about undernutrition, but also the burden of overweight and obesity. So all the forms of malnutrition present a significant health threat to human health. And today, as I said, the world is facing the double burden of malnutrition. But today, maybe we are focusing a little bit more on undernutrition at the state globally. So malnutrition remains the undernutrition, one of the most persistent and devastating public health challenges. And based on the latest report of the State of Food and Security, this is a yearly report that is supported by many UN agencies. Globally, malnutrition affects again and still 45 million children with wasting, and among these 45 million, 13.6 million are severely wasted, and 148 million suffering from stunting. I think in 2025, this is not acceptable to have these high numbers of malnutrition. But these numbers, again, they only scratch the surface, because malnutrition is not just about food. Malnutrition is about access. Malnutrition is about equity and the ability and capacity also of the health system to intervene before it's too late. Because we see also the levels of high mortality that are directly related to malnutrition. And in many settings, malnutrition is invisible until it becomes severe. That's why prevention must start at the primary healthcare and community level, where early signs can be detected and addressed. Prevention can include infant and child feeding practices, growth monitoring, macronutrient supplementation, management of acute malnutrition, and also counseling on dietary behavior change. These are some of the entry points at the community level and the primary healthcare level.
So true. Thanks for that, Fatia. Yeah, it's really underscoring that point that Fatia has shared, that primary care is really at the front line, for prevention. And I think I also want to link it with the discussion around integration of nutrition within the services of primary health care, both for early detection, but onward referral, depending on what the issues are. What we've seen in many cases, so for example, in some of the work we've done in Malawi, we've actually seen a significant decrease in under 5 mortality outcomes, just based on integrating nutrition within the screening, the early screening that's happening at the facilities. And the government of Malawi has actually adopted this. They've set up a 10-year plan that is looking on integrated screening and onward referral to chronic care or to maternal and child health services. And this is now integrated within their health service plan.
Thank you very much for sharing this experience in Malawi. Just to emphasize that primary health care is where nutrition integration needs to happen into existing platform. So we are not having these parallel interventions. And it is our first line of defense. It's where mothers bring their children for checkups, for immunization, and where nutrition counseling also can happen, and where growth monitoring becomes a routine. But too often what we see is that primary health care is under-resourced and disconnected from the communities it serves. And there is a tendency at country level to work in silos, implementing vertical programs, and sometimes it is really donor-driven. Sometimes the donor, they will give you funding and say, I want you to invest or to use this funding for HIV treatment, for example, without saying nutrition is important in the HIV treatment. But often nutrition programs also are not integrated in the health strategies. So nutrition is not seen as a health service, despite its importance. And of course, this will have an impact on how we are going to allocate resources, financial resources and human resources. So just to share with you a little bit my experience, when I was working with WFP on integrating nutrition into HIV program, I always felt that I was fighting, looking for my seat around the table, because nutrition was not seen part of partial of treatment, care, and support. And we had really, literally, we have to fight. And every time we are not at the table, nutrition drop. So we needed to be all the time around the table. We succeeded in having a kind of work stream on HIV and nutrition. We came up with guidelines. We succeeded in getting funding, but it was extremely very challenging because the donors were not interested in investing in nutrition, and they were more interested, or maybe because of course of the constraint in resources, more into the drugs and to treat. But we know that nutrition is important for retention. We know that nutrition is important for the treatment to be successful. So again, it was really a fight. It was not easy, but we didn't give up. And again, evidence suggests that integrating nutrition into services into health systems is possible and can strengthen health system, improve access to care, and also create demand for nutrition intervention.
Yeah. That's a great, yesterday we were talking about, and it's not just the role of donors, but it's really thinking about the whole architecture of how the global health architecture has been designed. It's been designed to focus on diseases, commodities, and because of the way and technologies, and because of the way it's been designed, rarely are we talking about the element of the health system that actually integrates all those three. And that's the people, it's the health worker. If you're talking about managing diseases, you're going to come back to the health worker. If you're talking about the drugs, supply chain, are we keeping on top of our orders? Are we stocked out at the facility? And then what do we do if we're stocked out? It comes back down to the person. If you're talking about the usage of technologies, whether it's testing, lab testing, or using the other technologies within the facility, it comes down to the person. And so, taking a thread from what you've just been saying, ultimately, even as we're having all these conversations about rethinking the global health architecture and how should we, enable countries, to be in the driver's seat and be country-led, for country health systems, it comes down to also how they're investing and how they're centering their health system around the health workers. And this discussion we're having is very important towards that. Where else have you seen, in terms of really making the case for focusing the investments on the health worker as part of building out the primary health system in relation to malnutrition management?
Thank you, Andrew. Of course, I think I just mentioned it, investing in human resources is extremely important. And we cannot succeed without a trained and supported and motivated workforce. Primary healthcare workers often receive inadequate nutrition training, limiting their capacity to provide essential nutrition counseling and intervention. And we need primary health providers to understand nutrition, who can collaborate with community health workers and who are empowered to act. And training must go beyond clinical skills. It must include cultural competence, communication, and community engagement. We have seen success where government and partners invest in continuous training, mentorship, and clear career pathways. And let's make this the norm and not the exception. And again, coming back to the community health workers, we think that they are the backbone of local health system. They are trusted, accessible, and often the first to notice when a child is losing weight or a mother is struggling with breastfeeding. But they need support, tools, supervision, and also recognition. And this is not always the case. And we must build systems that value the community health workers not as volunteers. And often they are volunteers, and we need to change that. They need to be considered as essential health professionals Integration means shared goals, joint planning, and mutual respect between community health workers and clinical staff.
Yeah, but and thanks for that, Fatia. Prevention is only possible if the health workers are trained. The community health workers are also trained and fairly compensated if we want to ensure that nutrition services are successful. And we've seen some examples of this. In Zambia's National Health Insurance Scheme, Uganda has just finalized an RMNCH financing case. Both stress the integration of nutrition. The big question for us, and this is staying as a question because I would like to invite our colleagues to share their experiences as well, is as we rethink some of these global financing mechanisms, the ability to fund at primary healthcare. I'm remembering a case, before I studied at SID, I was chairing the Uganda Global Fund CCM. And in the discussions around the Global Fund proposal for the country, for Uganda, we were having discussions about the inclusion of nutrition services in a way that, it's obvious if you think about it. Integrating nutrition within pediatric HIV services, for example, is important for retention, like Fatia said. But the discussion was always, this is a standalone investment. And why would we be taking money away from HIV services, from TB services, to put in nutrition, when it was actually one and the same thing? If TB patients are not, adequately fed, then that's a problem for the health system. But there was still the general thinking in those discussions that it was a standalone. So bringing it up to that global architecture and recognizing that even as we're respecting country plans that have this integration, really understanding that it's not a standalone. I think that's the last point I wanted to end on that Fatia had raised earlier. Any last thoughts, Fatia? I can see our colleagues can't wait to get on stage.
Yes, very quickly. So you mentioned some global coordinating mechanism. You mentioned the Global Fund, which is a bit specific on the 3 diseases, but it's worth mentioning also there are some global coordinating mechanisms like the Sun Movement. I'm sure most of you know about the Scale Up Nutrition movement that has a number of networks, civil society, academia, the UN network, but also the private sector, the business network. And there are a number of also new initiatives looking into new innovative financing. I'm going to just mention a few. There is the nutrition, the power of nutrition, that is a coalition of a number of strategic partnerships. I think there are 40 partnerships and reaching 600 million children and preventing 415,000 cases of child stunting, which is enormous. And also I wanted to mention Unit Life, a trust fund that is hosted by UNCDF that use some innovative financing like debt swap and conversion, which is working in a number of countries, micro donations and public-private partnership to address chronic malnutrition. And also I wanted to mention one last initiative, which is the Nutrition Integration Compact that has been launched by the UK government at the Nutrition for Growth Summit that took place in March in Paris, where partners succeeded into raising something around $26 billion for nutrition, which is very important. These are pledges, and now we would like to see how this funding and pledges will be translated into funding countries and funding nutrition programs.
Okay, great. So we'll end this session on that message of hope. The message of hope is that there is funding towards nutrition, like Fatia has just shared. 2, that national plans actually have this. We're starting to see this integration happening within national plans. And 3, malnutrition is preventable when embedded in primary healthcare systems. Now, we've been talking about this broader global aspects of this, but we wanted to invite some of our colleagues to share some of the practical work that has been done in country. And then we'll get some discussion going with the audience. Over to you, Raissa. Yeah.
Thank you. afternoon, everyone, and thank you to Andrew and Fatia for kicking us off. They've done a great work at setting the scene, giving us a sense of what nutrition and malnutrition has been like. They've talked us through trends, the nutrition trends, the funding trends. They've also given us the lay of the land in terms of the difficulties that we face in fighting nutrition, and even brought us back to a more of a hopeful note around the possibilities. And today what I'd like to do is bring up some individuals that I've had the pleasure of working with over the past 7 years who are capitalizing on opportunities to work on malnutrition. But perhaps before I bring them on, I should introduce myself. My name is Raissa Sorgho. I'm the Director of Global Nutrition and Partnerships at the Public Health Institute. And just last year, the Public Health Institute celebrated 60 years in supporting communities to improve their health, primarily through partnerships and synergies, and that's a lot of what you'll hear today. So with no further ado, I'd love to invite Oscar, Sarah, and Henry to the stage. Wherever you want. And in this second half of the panel, the three of them will give us concrete examples of how they have integrated nutrition in their institutions, in their work, and in their communities. So we look forward to having you introduce yourself, tell us a bit about your project, then we'll move into a moderated discussion session, and then we'll open the floor to everyone else in the room and online who would like to ask questions or join the conversation. And over to you, Oscar.
Thanks a lot, and good afternoon, all. My name is Oscar Kambona. I come from Kenya, and I work in a county called Siaya, if you can relate with the former president of America. Right, in terms of service delivery, this is the 24th year working together with the community to promote issues of healthy lifestyles among the community, and also eradicating malnutrition in all its forms at the community level. I would want to say that that is the basic approach that really helped a lot. And when we started the kind of integrated approach with the partners, the Public Health Institute, the Abbott, the KEMRI, which is a national research institute, on some of the innovative ideas that they were working on at the community level, then the work was triggered from 1 in 3 stunted to 1 in 5 stunted currently. And the work continues. Thanks.
Thank you, Oscar. Over to Henry.
Thanks, Oscar, and thanks, Raissa. It's really an honor to be here today. My name is Henry Sawe. I am the current Executive Director for the Abbott Fund Tanzania. I am based in Dar es Salaam, Tanzania, where I am responsible for managing Abbott Fund's philanthropic engagement in the country. The Abbott Fund and Abbott have been working with the government of Tanzania for the past 25 years. This collaboration has really focused on 2 key areas. The first one being health system strengthening, where Abbott's been responsible mainly to support the government with strengthening the entire health system, particularly human resource for health strengthening. We are responsible for establishing the first emergency medicine specialty training program in East Africa at the time, where to date we've trained over 100 specialists in the country, as well as training healthcare nurses and other providers who are already in service. Beyond the human resource training, Abbott's also responsible for supporting with infrastructural development, building emergency care unit, and models that are provided to the government for replication. We're also supporting the government with clinical quality improvement, as well as research work within the national, regional, and district hospital. Another area that the Abbott Fund and Abbott works with the government of Tanzania is in building livelihood, where we support children and families with education as well as economic empowerment to ensure that children who are very vulnerable get access to education, as well as the communities that are really having struggles economically gets a pathway that really provides them with sustainable economic empowerment. And another area that we work with the government is really around the orphanage community, where historically Abbott engaged with the government of Tanzania from the historical context of HIV pandemic, and that's really having had a long history of supporting that area has ended with the government and Abbott having a really collaborative initiative that's supporting the children. And so that relationship over the last 25 years, which this year we're very honored to celebrate the 25th years of the collaboration, has enabled various models that can be replicated across different parts of the world. And I'm really happy and honored to be here to share part of the work that we do with the government. Thanks, Raissa.
Great. Looking forward to diving deeper into that. Sarah?
Thanks, Raissa. Good afternoon, everyone. I guess I'm the only one freezing in this room because I'm missing the sunshine that is always in Nairobi, but I'm happy to be here today. My name is Raissa Sorgho. I work with AMREF Health Africa. AMREF Health Africa is an health NGO that is headquartered in Nairobi, and we have presence, physical offices in 10 countries in Africa. And where we don't have physical offices, we work with partners, and for those programs, we span across 35 countries in sub-Saharan Africa. Really happy to be here, and one of our core mission, our mission as AMREF is to transform the lives of communities through primary health care. And for us, it is core to what we do. And when we're looking at primary health care, we're saying it has to be people-centered, and also we have to focus on social determinants of health that drive lasting health change. And so for ensuring that the systems are providing equitable access to primary health care, we also look at leadership, governance, and work with governments to be able to strengthen the leadership and governance and provide accountability platforms for our communities. The other thing that we've focused on now, even in our strategy that is running 2023-2030, is the issues around resilience. And we've seen how shocks are affecting our health systems. And so we want to build systems that are able to withstand shocks, not only epidemics that we've seen, pandemics that we've seen, but also climate shocks, because we can no longer ignore. If we pride ourselves in saying we want to transform communities for lasting health change, and we ignore the effects of climate, we ignore the effects of pandemics in health system, then we are not true to ourselves. And so with AMREF, we're looking at how can we build resilient health systems? How can we improve livelihoods of communities? How can we improve education of communities? And how can we protect our health systems from climate crisis to be able to deliver quality, accessible primary health care? But today, I will delve into what we do in terms of getting to the forgotten cohort. And I think I'll go into details when we start to speak, because when we talk about malnutrition, most people will just go to under 5. What happens after 5 years? No one is talking about them. And I'm really excited to see how we can converse between 5 years and 18 years, where they are having issues of nutrition, their requirements is even higher, but nobody is talking about them.
Great. Thank you for giving us a sense of where you work, the work that you've been doing. I'd like to start with Oscar. One of the things that you said in your introduction was being able to move in your county of Siaya, moving from 1 in 3 being malnourished to 1 in 5. So I'd like to know concretely, what has your county been doing to help this progress, to make this kind of change happen?
Yeah, thanks a lot. In the morning, the sun rises, and Mary, in our local language you call Maria, wakes up. Maria is a health promoter, and the priority on her list is visiting one of the 100 households on that day. And that household is either for the lactating mother or a pregnant mother. So Maria walks into that household and again gets to engage with the mother on issue of nurturing the child. So the long story short, Maria goes and peruses the mother-baby booklet and realizes many other things. Some she can be able to intervene, and those include the ones that she can be able to give nutrition education, and if to the extreme, she then makes referral to the nearest health facility. The priority that Maria has given to this particular household reflect the priority of the government of the county and to extent the national government. So come when the sun is at the western end side of our continent in Africa, that's when the sun is setting, Maria is rest assured and already have the numbers of those she will have to confirm whether they attended the facility or not. Now, with this priority, one thing that is coming out is that Maria has to be capacity built. And with that knowledge and capacity, Maria then reaches out to the mother of this under 5 child. And again, with a little bit of the technical knowledge that Maria has, she's able to even evaluate a little bit the nutritional status using the simple equipment. So ladies and gentlemen, that whole scenario is just illustrating to us how we have worked in our county, which have 260,000 households being visited on daily basis by 2,128 Marias and a population of 1.15. So that opportunity of the strengthened community health services has enabled us, the proponents or the technical people in nutrition, to cascade the nutrition from the technical centers like the health facilities to the community. And that has actually filled in the gap of the human resource for nutrition ratio to the population. Because in that particular population, we have around 30 nutritionists, registered nutritionists, public health nutritionists, and clinical nutritionists.
Oscar, you bring up a great point around community health volunteers and promoters. And this is actually something that Fatia had brought up, the importance of valuing those members of both the community and also the labor force, the health labor force. So I'd like to get a sense of what kind of nutrition training do these community health promoters get? I know Kenya has just shifted from community health volunteers to community health promoters. That's a change that I applaud because it is doing exactly that, valuing that source of nutrition knowledge or health knowledge and that access to the community. So what kind of trainings have they historically gotten, and what do they receive now in terms of nutrition training?
Thanks a lot for that engagement. One of the key training that our community health promoters have gotten courtesy of the partners and the county government of the CIA. One is on MIYCN, maternal, infant, and young child nutrition, broken into the elements of complementary feeding, exclusive breastfeeding, and also growth monitoring programming. And one of the key tools that we now cascaded to them is what we call the MWAC for this core as a technical tool. And along into this discussion, we realized that when that tool was now cascaded to the 21, 28 of the CHPs, then we just enhanced the referral, and the rehabilitation time for the severely malnourished was shortened. So I think this gives me an opportunity to indicate and to show this innovative tool that is very rich in information, and this is targeting the over 5 years to 17 or 18 years of age. This group, we largely did not focus so much on them because we used to use the other adult tape for them, or we go to to check on the chart for this BMI for this score, and which is also a longer route. Given this to the community health promoters, then they're able to engage with the teenagers at their household level. But then of the greatest and the one that really influenced our work from 1 in 3 to 1 in 5 is the one for under 5 years of age. So this little gadget starts the measurement from 2 months, while the other traditional one starts it from 6 months. So therefore, we were losing quite a number of these numbers who were becoming malnourished between the months of 2 to the 6th month there. So this tool, all of them were given, all of them are using, and largely it gives them even more of the technical language that can help them engage with the households.
Okay, great. So you have talked us through formalizing your workforce, equipping them with technical knowledge, and also giving them simple tools that they can use on a day-to-day as they visit households, and those as being key components of making a difference in the detection of undernutrition and overnutrition, and then kind of introducing them to the path to care. Now, Henry, you mentioned in your introduction that that Abbott Fund in Tanzania has been training, has been part of the training workforce in terms of not just, I think you mentioned medical, was it the emergency medicine?
Yes,
and also nutrition. So I'd like to better understand how you've been able to integrate nutrition work in the existing work that you're already doing in partnership with the ministry in Tanzania.
Great. Yeah. So it's a really nice question, because one of the things that we've been working on in the country is really training health workforce in emergency care, as well as supporting the government with capacity building in different parts. Nutrition work had not been our work originally, but we had an opportunity earlier this year to witness firsthand the impact of nutrition screening in one of the East African countries where we had an opportunity to visit. And so we took an initiative of saying, let's try and pilot the malnutritional prevention integration into our program without creating a separate program. And which was very important, because most of the time when this malnutrition prevention program are thought of as a parallel program. What you wanted to do is to establish a program that's really integrated into a program without doing that much. We did literally only 2 things. We did not need to establish a separate program or have a separate funding. We only capacitated the healthcare providers who were training, as well as giving them the tape that Oscar just showed, and really have malnutrition prevention integration become part of a program. And essentially, when we go out into these outreach programs, whether it's in a clinic, whether it's in a primary school, a secondary school screening program, we only allowed and added the screening of malnutrition as part of that program. We thought that is important to do it that way than having a separate program, so that it becomes sustainable. So that becomes part of a daily screening program, so that it becomes part of the hospital program, which is very important, because if we had started a separate program, then it would have meant that this is a parallel program which needed a separate funding, which needed a separate mechanism, which needed a separate leadership, whereas of now is an integral component of a daily routine for clinical care, for screening and prevention. The hope is, over time, this becomes an absorbed program within the entire government system. And just to share, in the last 3 or 4 months that we've been doing this pilot, we're able to screen over 2,000 children and identifying malnutrition to 30% of them and linking them to care, something that really shows how impactful this passive integration, we call it passive integration, can work within our system.
Yeah, I think that touches exactly on also the theme of the summit this year. We're talking about fragmentation of our world, and in this session, we've really gotten to see the fragmentation of nutrition work in health work. The fact that, as you said, sometimes it's brought on as a parallel program, as a different program, or as an add-on program. So it's great to hear of an institution being able to really just integrate it as an additional step within an existing program, and how that then facilitates uptake within a government because of the running system. Sarah, now you guys are using a different approach when it comes to integrating nutrition and bringing nutrition really into the equation. So can you tell us a bit more about that? And then we'll get to talking about that age gap that you mentioned earlier.
Thanks, Raissa. And I think it's really clear that you can go further if you use what you already have to be able to layer onto the program and ensure that that patient journey, that one person that comes to the health facility receives holistic care. And so for AMREF, what we do, I think I mentioned a little bit about our focus on primary health care. And so whatever we do in strengthening primary health care is done at that facility level, and we ensure that it's holistic, so that you don't have siloed programming. And because we also have many, many programs that we run in country, and so there are chances where you will find a different project implementing differently. But then at national level, what we do then is to make sure that we have clear mechanisms for implementation. So integrating that primary healthcare and working with county government. So when he speaks about CIA, as AMREF, we don't do the direct implementation ourselves. We work with government, and so we strengthen that capacity. We provide facilities, we provide technical support for them to be able to deliver primary health care. So we do primary health care. There is also capacity building, because fit-for-purpose health workforce is very critical. And I know someone said people perish because of lack of knowledge. And that is true up to some point. But what they do with that knowledge is also very critical. So you know that you need to do screening, for example. So you've done screening, and so what? And so that loop of ensuring that we are engaging communities, community engagement, working with them to develop and co-lead solutions for malnutrition and general health well-being is also critical to what we do at AMREF. And for a long time, community health system strengthening has been our core. And looking at the last mile, when you go to the most remote places in countries of our implementation, chances are you'll find AMREF there, because then we know those people at the last mile are usually forgotten. And if you look at the entire ecosystem, then you also focus on the different age groups, the different population cohorts, to be able to deliver for them and find them where they are. And then lastly is about generating evidence for decision making. It's gone are the days where you just decide to say you go to county X and give them resources for XYZ. No. What is the data saying? How are you using that data to actually provide solutions that is going to serve a need for that community? So community engagement for us through community health care workers, but also community dialogues, is very critical, and we integrate that in our day-to-day implementation.
You've brought up so many great points. I'll just pick a couple to go off of. First, you brought up community co-design as an important component of ensuring that the community is part of the work that you're going to do. And it seems so obvious, but I think for many, many years, communities just received whatever intervention it is you had planned, at your headquarters, in your office. So I like the component of community conversations, community co-design before you begin a project. You also brought up data and the notion of decision-making being data-driven, and also projects and programs being data-driven. In my work with Oscar, that's actually how we began working together, was through a research project. So we had a randomized controlled trial that academia did in partnership with KEMRI, the Kenya Medical Research Institute, and also the Siaya County government, where we explored questions that were of interest to the county government of Siaya, which means that they were there from the beginning of the research to the end of the research, and then of course to everything that came after, because they were then there to continue the work that we had started together based on the findings that we had. And I'm always so happy to speak to Oscar, because I get to hear more and more about the continuation of that work. Another component that you brought up were gaps in the work that we do. And one of them, unfortunately, is adolescent health. We talk a lot about child nutrition. We talk a lot about mother and child nutrition. We talk a lot about pregnant women and nutrition. But when it comes to adolescents, that kind of falls out of the picture. So I would love to hear a bit more about that work from you guys, where the interest is and kind of what's coming next.
Yeah, thanks, Raissa. And I think this was prompted by the fact that when you go to Kenya, you will find that most of the majority of the malnutrition work is actually focusing on under 5 years. And yet, even the statistics on the levels of malnutrition, the acute malnutrition, you'll find all the data you need for under 5. And every year there is a short survey that is done, it's under 5. And yet we know where the problem is. After 5, nobody cares about you as a child. And even it gets worse as you get to 14, 15, 16. By 18, you're already seen as an adult. No one, I mean, go ye and make money and become an adult. But what we forget is the fundamentals that they require. The nutritional needs for that age cohort is huge. The micronutrients that they need, sometimes they don't get because of either it's the choices, either it's not because it's not available, or even peer pressure that now we're no longer eating vegetables because we don't want to eat vegetables. So that, in effect, affects their health and well-being. And so even when we were trying to design this program, the data was scarce. And so the only solution was to go and hear from these adolescents. We hear from caregivers, we speak with mothers, how is nutrition issues happening in the household. And all this happens at the household. So speaking with the caregivers, speaking with the adolescents themselves and co-creating solutions for them, and then reaching them where they are. So you'll find that you cannot only go to the health facility, because routine immunization ends and 5-year-old will come to the facility when they are ill. And so where do we find them? So we thought schools is a place to find them. We thought households is the only place to find them. And that is where even health is being cooked at the household. So working with mothers, working with caregivers, working with schools, and you'll find that in schools there are school health clubs, and mostly school health clubs will talk about sexual reproductive health, and nutrition is again forgotten. And so what we're doing now is ensuring that it's integrated and not seen as an expense, but it has to be seen as an integral investment in human capital.
Great. So capitalizing on existing structures where you already find adolescents and then using those as a means and as a pathway to reaching them. What I like about this panel is that you have discussed nutrition programs at different levels. And maybe I'll spin and talk this direction since I've had my back to you most of this session. Sarah is talking to us about co-designing a program, which is the earlier stage of that process. Henry has talked about piloting integration within existing programs, and Oscar has really introduced kind of the array going from the research to the implementation and then to the scaling. So Oscar, I wanted to ask you if you have any lessons for those of us in the room when it comes to scaling work, when it comes to scaling the impact that you saw in Siaya during the research, and then now rolling it out to the entire county.
Yeah, thanks a lot, Raissa. In terms of scaling out the new technologies within the county government of Siaya was relatively easy because number one, we capacity built the community health promoters, and they also worked together with the researchers. Two, I can say that we stipend our community health promoters, 50% national, 50% county government. But beside that, we appreciate the fact that community unit is a planning unit. So our planning is bottom up, whereby the community now, with this new tool, they incorporate it into their own activities. In terms of, again, sustaining it and getting that particular activity, the facility technically working with the community health assistant to support the community health promoters. So it's a layered kind of approach system that helps to monitor, support, and give technical assistance where necessary. I would want to say that why is that growing, mushrooming so fast? Due to the fact that we appreciated the community health promoters and other volunteers is after several researches that was done prior to the devolution in the Kenya, that's before 2012. And after 2012, my county picked up that element of research and established community health services. So as we are talking right now, it's 100% coverage for the entire county, and it's to the tune of around 73 million Kenya shillings per year as their stipend. And we also appreciate that they also feature in our work plans at all levels, from the community to the county level.
And I think, Raissa, to add to what Oscar is talking about is how Kenya has embraced community health strategy, so that at community level, you have the supervisors who are the frontline healthcare workers who supervises community health promoters. And then these community health promoters have been put in units. They're called community health units. And each unit has about 10 community health promoters that serve up to 5,000 population. And in that, then, it helps to draw down the primary health care to the household level. And it becomes an enabling environment, even for partners like us, to easily go there and implement and work with communities to deliver services.
Okay. I think Kenya, for those of you who might not know, works through a devolved system. So what they were explaining was the breakdown of that system at the county level and seeing how they can utilize the structures of that system to support programming. Now, Henry, you work in not a devolved system. So yes, can you talk to us a bit about what that might look like when it's more of a national system or just in a different context?
Yes, absolutely. Yeah, we have a centralized system which works in a pyramid fashion. Our healthcare system is ranged from top of national level hospital to primary level hospital. The lessons from a country like Kenya, where it's a devolved system, and how can be replicated in a country like Tanzania, is through an integration of malnutritional screening, prevention, and management to the lower level of healthcare system, where everybody is, where it's an entry point, the primary level health facility. We have community health workers, some who are incentivized and some who are not, mostly not incentivized. And the primary level entry at the level of the community, where everybody accesses the healthcare system from the first point. To us, I think, based on the experience we've gotten from the pilot, is if we are able to make malnutritional screening be part of the regular care. That's number one, at the primary level. But number two, be part of the regular screening. Number three, be part of the regular vaccination program. As Andrew said earlier on, every healthcare worker is a nutritionist, meaning we shouldn't create a parallel nutrition program in a health system, but rather just make it a go-given for any healthcare system. That means you are consolidating your resources towards screening, you're consolidating your resources towards directing care, and that's what we saw really in the pilot that we did, that it was very easy to just introduce a tape and a modest capacity building to a healthcare provider, identifying these people and linking them to the very same system without really requiring a parallel resource to doing that. That's how this can apply in a country like ours.
Okay, great. That's a great lesson from Tanzania. And I think now I would like to give each of you a chance to share a closing word. I also really like the quote that every health worker is a nutrition worker, because in essence, you have to be. You cannot build health upon an unstable structure, and someone who is not well nourished is unstable in terms of the health structure that you'd be building upon. So maybe starting with Sarah, any closing words?
Yeah, so I think we've said a lot that needs to happen when it comes to integrating nutrition to primary health care. And I'm hoping we will leave Berlin with the thought that nutrition is not a different expense. It is supposed to be integrated. We need to put it in the primary health care. We need a fit-for-purpose health workforce, and we need to use evidence to drive action. And so when we leave here today, I'm hoping then we carry with that mandate to ensure that nutrition is not an expensive outcome for us to be able to deliver, but then we have to make sure that it's fundamentally included in what we deliver day to day and ensure that we are building that across all systems of the healthcare.
That plus, it doesn't cost that much. It really doesn't cost that much to add malnutrition prevention as an integral component of a healthcare system. The reward to that is significant in terms of really long-term morbidity and mortality. Statistics are out there, and so we should really focus on putting malnutrition prevention and management as part of the care, because they will give us reward when people get sick.
Wrapped it up in the story of Maria, we've come to learn that investing in community and letting them leading the initiatives, guided by the technology, malnutrition loses ground. Thank you.
Thank you. I'll now invite Andrew and Fatia back to the stage. And now is a great time to take questions from those of us in the room and those of us online. There are a couple microphones which I will hand over this way, and maybe you can, there's someone who's ready.
Okay, thank you. Is it on? Yeah, I think so. Okay, thank you. So my name is Andreas Bergloff. I work as a policy advisor at WaterAid. I haven't heard WASH being mentioned at all today. I mean, diarrhea, for instance, or other illnesses is a major driver for malnutrition. Considering also the healthcare facilities, there is a majority of them, or a large proportion of them, accessing clean water. You can't wash your hands, there are pool latrines, and in the households, the mother who has to go in the river or lake to fetch the water that she's cooking food on. So I just want to ask you, I mean, how do you consider, I mean, the infrastructure of WASH, water sanitation and hygiene in the malnutrition area? Thank you.
Go ahead,
Yes.
yes. And
Thank you.
also,
Okay,
just before
go
you
ahead.
go, you may not be in the hot seat, but you are still in the hot seat. So feel free to also direct questions to the second panel. Go ahead.
Thank you very much. This is a very good point, sir. I think wash and hygiene are extremely important in addressing this integrated approach of health. At the health facility, of course, we are integrating nutrition, but wash is also very key. I worked for WFP for many years, and we have a very good relationship and working relationship with UNICEF. You know, within the UN, we have this division of labor, who is doing what, etc. And UNICEF has been really in the forefront when it comes to water and sanitation. And again, someone mentioned something about the last miles. This is where we have all to come together and to offer this package of services to the population we are serving. Thank you.
Yes, Oscar?
Yeah, thanks a lot. We only brought in, thanks a lot for the question. We only brought in the element of nutrition. However, it is a whole package with our community health promoters. The very first training that we took them through was called Integrated Community Case Management. And even as we, right now, currently, they are able to do the RDS, the random test for malaria. They are now being integrated to the issues of HIV. When it comes to the WASH, they are the greatest promoters of the hand washing at the community level. They also, we also have, through the evidence action, the community points for water. And they're given the chlorine and other disinfectants that they can be able to distribute within that community setup. And again, also, we use them as point of referral. And any referral by community health promoter is recognized and appreciated and given very fast service at the health facility. So WASH program is integrated amongst many others at the lowest level in Siaya County, Kenya, as a country.
Over here, and then over here.
Thank you. One of the projects that I think was implemented in Kenya looked at financing, household financing level to address malnutrition and other childhood illnesses. I am not so sure if any of the team contributing here knows how best this can be used as an avenue, because then it empowers the household level and probably breaks the chain of dependency. Thank you.
So the question, if I can repeat it, is around household financing and how that can be utilized to break dependency.
So I could respond to that. I think I mentioned earlier when I was speaking about some of the social determinants of health that we focus in as AMREF, and livelihoods is one of those. And so improving the livelihoods, improving household incomes is also a driver for better health, because someone is able to buy health, someone is able to pay for transportation to go to a health facility, someone is able to subscribe to the social health insurance funds because they have something in their pocket, but also they are able to get the nutritional foods that they need at the household level. And we've seen how even during crisis, how cash transfers can transform outcomes for that household, because then they are able to get the essential things that they need for their household. And this is one of the drivers for change, especially in the nutrition piece. And I think earlier on, Fatia and Andrew had mentioned about how financing is integral. But we're saying beyond financing, there are those non-financial drivers that we also need to focus on. Issues about capacity development, issues about working with these communities to understand that don't go selling your milk to buy bread. Don't go selling your vegetables to go and buy a processed kind of food. And so all this with education and working with communities for them to understand the holistic essence of nutrition. And then brings now the other social determinants that we're talking, water sanitation. How do you do also issues of food security? How are you going to handle the choices of foods that you have? Is it a balanced diet? Because someone else will just say, I'm eating potatoes, I'm eating this because this is what I like. But there are other things that you need. So education for us, I think, is important beyond just the livelihoods at the end of the day as well.
Oscar.
Yeah, thanks a lot for the question again. In Kenya, yes, it's ongoing. Some stipend is given to the families, additional to what my sister said. And I will also want to say that in the guidelines that is guiding all this cash for transfer, vulnerability, one of them is malnutrition. A severely malnourished with a pointer to vulnerable household gets two support from the two levels of government, the county government and the national government. One is SHA registration. The county government are now doing it so that you can access as a household that free, that health service insurance. Two, to promote food security, the government also pop in or give out some cash so that it can help you to pick up. And not only children are targeted, but also the geriatrics, the elderly, beyond 60 years of age, according to the elderly guidelines, national elderly guidelines in Kenya. Thanks, and over to you.
Yeah, there's a question just to add a little bit from the work we also do. In addition to this, one of the things that is really important is to ensure that there is a sustainability within families, especially those who are very poor. One of the work we've done in Tanzania, for example, is creating an economic empowerment initiative that centers around nutrition as well as income generation. Just a quick example, giving a cow and creating a pathway for a family to have a dairy product that ensures that the kids are able to get the nutrition from the milk as well as the sales that generate income to buy nutrition has really proven to be very successful as a program that we started in Tanzania. So that's another alternative model in addition to what's been said.
Thank you.
Here's we'll go here and then over to you.
Thank you. Thank you for the presenter and the result from the implementers. I'm Esto Baizire. I've worked a bit in taking care of malnourished children, undernourished especially, and I've seen that malnutrition is complex. It's too complex, and as I'm a bit lazy, I'm trying to go away from malnutrition and do some other stuff. But still, we have seen that kids from the same household are coming back to the clinics. We have this issue of wealth in the community. This brings up also the question about sustainability of the cash transfer and the stipend which is being given. So I want to ask to the presenters and maybe a specific question to the CI experience. What about the wealth of this community coming from one third to 1/5? Was it only due to the community integrating nutrition in primary community healthcare, or was also some kind of improvements at the community level in terms of food security? This is I think this is one of the first things in the community to reduce malnutrition. Thank you.
Go ahead, Oscar.
Thanks a lot. So how did we move from 1 in 3 to 1 in 5? Not a simple mathematics. Very complex. Number one, we engage the community-based organizations who are working either directly with the community in support of nutrition or indirectly. Number two, we established stakeholders right from the ward, where now the CHPs will be able to engage with the stakeholders, again in support with the CBOs. Now, I also want to say that we also had a technical working group across departmental level. And departmental level mean now that we approach malnutrition in form of a team of health team, agriculture team, water, education. So education initiated school feeding, where they'll give one meal in a day to promote the admission, retention, and the transition. Now, agriculture also had promotion of the locally available food crops within the community there. So health now brought in the element of minimizing the mortalities and also increasing the referrals, and then the rehabilitation with a high cure rate. We realized that that will be able to mitigate the impact, the immediate impact of malnutrition. However, as agriculture is incorporating the kitchen garden and using the team of community health promoters and extension officers to visit the homesteads, then we realized that there was now a continued use of locally available foods, and additionally, the importation rate of our county from other counties reduced from largely 60 to now less than 30%, because now we use our own resources for production. Now, that notwithstanding, we'll also want to correlate it with the fact that nationally, our county is always number 1 or number 2 in terms of HIV infection. Now, the drastic reduction in that prevalence as well is also a pointer to the benefits of the health that we are getting out of the interventions in the HIV and the TB programming. So it is not, we appreciate that it's not a single source cause for malnutrition. So the entire county engaged all system to approach the malnutrition. I don't know whether make it.
Yeah, I think you've really gotten to the point. Malnutrition isn't a single source issue, so it cannot be a single source solution. And in Siaya County, for example, they really do have these systems integrated. So when a child is screened and detected as undernourished or overnourished, it also flags a number of other components. So it doesn't end at just, okay, we found this child and we focus on them. There is a household visit that happens. And during this household visit, as Oscar mentioned, you will have the Ministry of Agriculture who will step in and see if there is a possibility of supporting with growing food. You'll have the Ministry of Social Services step in to get a sense of what the household situation is like. This also kind of brings in a number of other services. So nutrition can be the starting point, but knowing that it can't be a single source solution means that they do bring in all the other services to ensure that you kind of tap at all these other components that are part of the problem and the solution.
I just want to say something. I think that there was an intervention saying nutrition is complicated. And sometimes I think we need to be careful what we wish for. We said every health worker is a nutrition worker. And we have the reputation, the nutritionists, to be very complicated people. So, no, seriously, I think there was the intervention about WASH, for example. Nutrition is complicated because it's multi-dimensional. It's not like, okay, I have malnutrition, I have to give food, I'm going to solve the problem. No, it doesn't work this way. There is WASH that is involved, the environment, and again, the colleagues, many interventions spoke about cash-based transfer, but also social protection. All these, programs that are extremely important if we want to sustain our fight against malnutrition. And you mentioned rightly that malnourished people, they come back, they are treated and then they are back. Education is extremely important. So it's complicated, you are right.
Thank you. Here is Alard Wan from International Pharmaceutical Student Federation. My question to Fatiha. My question is, in Gaza, many health centers are damaged and people can't easily reach doctors. How can we make sure that nutrition and malnutrition care are still part of primary health care in such difficult situations? Thank you.
Thank you very much for the question and for pronouncing my name so nicely. Yeah, I think the situation, we work a lot also in conflict situations. If I take just the work WFP is doing and the programs we are having in conflict situation, not only in Gaza, in other settings like in Sudan, in Yemen. And again, I think we need to have the workforce and the base to provide services, even though, as we also say WFP is the biggest humanitarian organization where we work and we have this last mile. So we have the logistics capacity to go and provide the support that is needed. And I think because you asked specifically the question about Gaza, I think now is the time for, hopefully, we are going to be all hopeful to say the time of reconstruction and to hopefully change the life of people. Thank you.
Yeah, that brings up an interesting point around the immediate treatment of malnutrition and then the continuous treatment of malnutrition. So you can have cases that are dire and require treatment just in that moment, but the follow through in that process is just as important. I had seen a hand over here.
Yeah, hi, my name is Mubarak. First of all, thank you for the amazing discussion so far. I think at the start of the session, Andrew highlighted the challenge of workforce. And I believe there's like a widely cited data on 1 to like 40,000 patients or like physicians. And in light of that, and also in light of recent push for recognizing like traditional medicine use and integrative medicine, I was wondering, what is it a discussion in your programs, the use of traditional health practitioners? And do you think there's a future of using that as a tool for improving service delivery at the primary care level?
Thanks a lot. That is not the dream. The dream is using the CHPs, and the dream is promoting skill delivery, service delivery. So we've gone down into scaling everything to do with the, sorry, I'm mixing it with the traditional birth attendants. But the traditionalists, they're still there, though they're not part of the standard medication in the national and to the county. They're still doing it as parallel. but I think, I may not say much about it, but our current focus is that we get the standard medication and health service from our facilities.
Go ahead, Sarah.
Yeah, so I think even when all this conversation starts is because at community level, you don't want to ignore those people who can be influential. And you will find that this group of people are very influential, and even if you went and preached to everybody, they will still go back to them. And so the question is, how do you bring them on board and to be used as advisors, as companions, or also guidance for the communities to be able to access care at that community level. So bringing them on board, if it is part of the community health promoters or part of the community health strategy, so that they are a resource at community level, and they're the ones actually who point people to the direction of where they need to get the services. I also now want to also speak to what about you spoke about the conflict zones, but outside conflict zones, I'm also speaking about sometimes climate crisis affect our health facilities. Last year in Kenya, between March and June, we had like 64 health facilities that were completely cut off because of heavy rains, and so they were marooned, they were not offering services. And it means also that we also had about over 500,000 people who were displaced, who are living in camps. So what happens then to their antenatal care? What happens to their nutrition? What happens to pregnant women? So what we do as AMREF is we have mobile clinics. So we have a whole truck, a fleet that has a cold chain there that is powered by solar, and you're able to go to the camps and offer those services, but also using connections, digital tools to be able to speak to whoever is cut off on the other end, to be able to provide the basic services that they can get. So looking at such tools to be able to deliver even for people who've been cut off because of climate crisis, I think is critical to ensure continuity of care.
I think you bring up a great point about sustainability and resilient systems. So multifaceted systems, that is one way of making sure your system is resilient, so that when your primary path of delivering care is no longer an option, you have other methods of reaching that population. And to go back to your question about traditional systems, for example, Burkina is working on formalizing or formally bringing in traditional care into what we recognize as kind of standardized healthcare. So they are working on recognizing that, bringing in the practitioners into the fold of the healthcare system, and then seeing how, instead of having parallel systems, they can work together, using the traditional health provider as a referral point, for example. So allowing them to understand, okay, this is something that I can assist you with, or this is something that you should actually go to the healthcare service. So that's been a changing point in Burkina. Instead of not recognizing them or not bringing them in, using them actually as a referral point for the healthcare clinic. And I mean, it remains a difficulty because in a lot of areas, there isn't that much connectivity to the health center. If your health center is still an hour away, then people are more likely to turn to their local sources of health before they get to the clinic. And I believe you had a question? Yes.
Thank you. My name is Sarah. I work at Action Against Hunger in France. Thanks a lot for affirming strongly again that nutrition needs to be integrated in primary health care. I mean, we know it, but it's always good to hear it again. So thanks for that. I had a comment that I wanted to emphasize the fact that to going back to Kenya, for instance, having a strong community health system that is working is key. But it's going to work if you have a health system that is working in the back.
Absolutely.
Because once you have diagnosed all these children or mother or adolescent that are suffering for undernutrition, then what? So just this remark to emphasize the fact that we have to think in a systemic way that start at community level but go up to the national level, which is quite important. And also pointing out the fact that integration of nutrition services is not only at the service delivery space, I would say, but it's systemic. So we also need to think of information system, health workforce. I think you highlighted it strongly, but it also goes to supply chain, and then more broadly, financing, governance, which is even broader. But if we want the system to sustainably integrate these nutrition services, we need to have this big picture. And the last point I want to raise is with an example of a program we are running in Mali called Aledia, where we are actually assisting the Ministry of Health to integrate nutrition services in a district level, so a bit like in Kenya level. And the solution we found to have a relevant integration of these services was to have a bottom-up approach and to making sure that solutions of the problems that were raised were coming from the communities, from the local CSOs, from the caregivers, and from the district authority, which ended up to work quite well. So it's more an advocacy work that I'm spreading, to have a look at the health system as a whole and to keep valuing the bottom-up approaches and the local knowledge around the nutrition. Thank you.
Thank you for sharing that example, and you're right. For example, in the work that Oscar and I were doing together, we conducted this research project and it bubbled up all this great data. And then we started using an improved MUOC tape, which gave us even more information on the nutrition status of the child. But the data entry platform really only asked for one metric, even though we had 4 metrics, which we thought were now very important in helping us continuously monitor the health of this child. So the next step in the conversation was actually talking about the data interface. How can we get the county and then at the national government to expand the kind of data it collects around nutrition? Because now we do have more data coming in from the community. So I totally understand what you mean about integrating it not just at the delivery, but also all the way back up the chain. I think we have time for one final question, but the speakers will still be in the room, so you have a chance to interact with them after the session's over. And last but not least, you might need a microphone. Oh.
Thank you so much for the opportunity, and thank you so much, speakers, for sharing your important work that you are doing around nutrition and primary health in general. My name is Mwajabu Mniga. I come from Health Focus, a private consulting company based in Potsdam, and we are working on health topics, including nutrition. I have been following the discussion. It's amazing to hear how much we are working and we are using similar approaches. We are using similar models, which are very successful. The saving groups, the care groups, the economic empowerment approaches that are implemented in different countries, whether it's in Kenya, in Malawi, in Burkina Faso. My question is, how can we best package these good practices, success stories, in a way that we can attract and improve appetites of government funders to put more money, more resources into nutrition projects? Thank you.
I think that's a great question to actually lead to the closing of the session.
Yeah.
So if take it away.
Yeah, and exactly. That's at the beginning of this session, colleagues. I remarked that you don't end up in a malnutrition session by mistake, right? You come because you deeply care about the issues we're talking about. You deeply care about strengthening primary healthcare systems, and you can see from the questions that the aspiration of this session was advocating for this. And we've actually had people advocating even more than those who are speaking here. So for me, I take that as an excellent mark to this session. So a couple of things just to close it. Number one, that conversations like this, places like this where you have policymakers, government, funders, implementers, are exactly where we should be having these discussions, where we should be sharing what has worked, like our colleagues from Kenya have shared, and where we should be challenging some of these notions. For example, our colleague was talking about WASH and saying, hey, it's a complicated system. It's not just about talking about nutrition, talking about WASH, but really how do we come together to understand that it's a complex system, but ultimately, if we are funding primary healthcare systems, if we are focused on prevention, we save costs later on in terms of health systems, especially for the countries where most of us work. So I think that's number one, taking away from there. Number two is really that malnutrition is preventable when embedded within primary healthcare systems. Number three is that even as we invest in these systems, we're trying to think of the resilience. Our colleague talked about conflict situations, and others have talked about other situations. The reason you invest in creating these resilient systems is so that if a pandemic comes, if a cholera outbreak comes, if Cyclone Freddy, like what happened in Malawi, comes, and you have already built a strong primary healthcare system, you're able to withstand this. You're able to withstand as you rebuild. And so that was the message here, and really grateful for all of you for your time, grateful to Abbott World Health Summit, and we will still be around to continue these discussions. Thank you very much. Yeah.